Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast, and this is my favorite one to do every year. This is our look back at this year in psychopharmacology for 2023, and with me is my good friend, Dr. Roger McIntyre. How you doing, Roger?
Andy, good to see you. Good to work with you. This is always fun. Lots to talk about. It's been quite a year.
It sure has. A lot of new medicines are approved here. Like I say, Roger, a lot of new toys to play with, and then some updates, some new indications for some existing medicine. So we got a lot to talk about. Let's get going. The first one is a little controversial. This is a monoclonal antibody directed against amyloid for Alzheimer's disease. And we had one approved a couple years ago, Roger, that was very controversial. That was aducanumab or Aduhelm. And the data on that was, controversial plus minus. But this one has a little bit stronger data, I would argue, and it's called lecanemab. What do you think about this, Roger?
I think about this, Andy, in a couple of different ways. First of all, look, we are all aware of the unmet need with respect to therapeutics to delay progress of cognitive deterioration or regress of cognitive function, if you will, in people who have major neurocognitive disorders like Alzheimer's disease. And it's interesting, Andy, as we know that historically there have been various attempts to look at neurotransmitter modulation like acetylcholine or even glutamate targeting for people living with Alzheimer's disease. But what's so interesting is the disconnect. For decades, people have implicated molecular biomarkers like amyloid and phosphorylated tau, and there's literally been in the hundreds of studies trying to target amyloid with little success. But finally, we got success. And we got success in the sense of we have a signal with this product, a signal that has been interpreted by FDA to be meaningful and, of course, statistically significant. But there's also something else here, Andy, which caught my eye when I first heard about this class of drugs being FDA approved. We're looking for, in psychiatry broadly, not just in Alzheimer's and major neurocognitive disorders, therapeutics that are mechanistically informed. And the closer we are to mechanisms in our targeting, the closer we are to disease modification and cure. That's a conceptual issue, but an important issue. So I think for the amyloid, the proponents of the amyloid theory of depression, this absolutely has to be a very positive FDA finding, FDA review.
Yeah, as a matter of fact, just yesterday I recorded a podcast with Dr. Danny Cabral, who's on our faculty. She's our Alzheimer's dementia expert. And she opened my eyes a little bit. I was a little skeptical. I thought, amyloid, by the time you're just sucking amyloid out of the brain, it's kind of like the horses out of the barn. It seems like it's pretty far down the pathway. But what she said was, look, this particular set of studies was shown to delay progression by up to 6 months. Yeah. And, if we're talking about oncology, Roger, chemotherapy, that would be a huge win, extending life by 6 months.
That's a nice benchmark. It's a nice benchmark. As you know, Andy, this does involve MRI as well on the safety front.
That's right.
With respect to, look, whenever you're targeting a protein, whatever that protein is in the body or the brain, the immune system often has a reaction to that. And that could result in some vascular permeability or some local inflammation, in this case, some swelling. And so as many as 15 to 20, maybe a little higher percentage of people may have this. And of course, the concern is bleeds and things like that. But taken together, I think your point's well taken. That benchmark to other therapeutic classes or therapeutic areas is very well taken. I agree with you.
Yeah, that safety issue you're talking about, they're called ARIAs, and they can be either edematous or hemorrhagic. Right. And ARIA stands for amyloid-related imaging abnormalities. Right. And you're right, it's either an inflammatory or the fact that these amyloids are so intertwined with the vasculature that if you sort of rip them out, you can destabilize the permeability. So you're right, that has to be monitored. Fortunately, the majority of them are asymptomatic, but occasionally you can see seizures, and there were a couple of deaths, sadly. Interestingly, Roger, there is a registry for people who are getting paid by Medicare, but there's no REMS program. I was a little surprised to hear, because usually when you have something serious like that, there's a REMS, but...
Yeah, I agree with you. It's an interesting sort of partnership with respect to surveillance of the product with as public and private sectors are both participating in this.
That's right. Well, overall, the other thing Dr. Cabral told me is this has been shown to delay cognitive decline, but also to improve function, which, of course, is the goal here.
Right.
So, I'm very excited. I consult with pharmaceutical companies. I've reviewed a lot of interesting protocols recently for Alzheimer's. As you can imagine, there's a lot of research going on and some really interesting mechanisms. Of course, one that you'll be especially interested in, of course, are the GLP-1 agonists. And Novo Nordisk is studying Ozempic. There's an active trial right now for Alzheimer's. We know that they're very, very neuroprotective, very anti-inflammatory in the brain. Of course, you're studying them for mood.
That's right.
But there's many others that are working on, for instance, synaptogenesis and neuroprotection, other things that are targeting the insulin receptors and glucose utilization, various anti-inflammatory. So it's very, very interesting time here. And hopefully we'll... while this is certainly a step forward, hopefully we'll have more things as well.
Yeah, well put. And, the GLP-1's interesting because just like these monoclonals, GLP-1 is also anti-amyloid. It has a direct anti-amyloid effect. I'm not sure if that's necessarily a convergent mechanism of all the therapeutics you mentioned, Annie, but
no, I don't
certainly it's one pathway. But as you just mentioned or you alluded to, there's many different ways you can actually approach this. But I think it's a very promising time. It's a promising time for Alzheimer's therapeutics.
Yeah. Something, Roger, I've always wondered about. I mean, if you do autopsies on people, older folks, there's a lot of people who don't have symptomatic Alzheimer's that have amyloid in the brain. So, is this really the central mechanism? Is it a byproduct? We don't know.
Right.
All right, well, let's move on to some other interesting treatments here. We've had a number of interesting approvals in the schizophrenia realm, and actually 3 different long-acting injectables were approved this year, Roger, a real cornucopia. The first one is one that I would not consider a major advance. This is a risperidone long-acting injectable, intramuscular injection, every 2 weeks, and it uses the microspheres technology, which is actually very similar to the first atypical LAI, which was risperidone consta. It can be given 1 or 2 months. It can be given every 2 weeks. Excuse me, and it's called Rykindo. Now, the advance here, if you can call it that, is you're shortening the period of oral overlap from 3 weeks of oral risperidone to only 2 weeks. And there may be some other advantages. So, certainly a nice addition to our armamentarium, not necessarily groundbreaking.
I agree. Look, it's incrementalism. I don't think it's considered a significant leap forward. But look, I think we have different options. I think that we need more options. This is yet another option. And I think for some people that oral overlap is maybe of appeal, and so on. So I think it represents, I agree. I think it's more the incrementalism, but it's another option.
Well, of course, from your point of view, for mood disorders, it's one of only 2 LAIs that does have an approval for bipolar 1 disorder. For maintenance, so that's certainly good news. Now, I consult with the company that makes this. They're called Luye. They're a Chinese company. They have other things in the pipeline, and I kind of feel like this might be their toehold, if you will, into North America. So could be the harbinger of things to come. Now, another one that I do think is groundbreaking, although not a totally new molecule, is another risperidone LAI, but this is a subcutaneous injection. And boy, if it was me, I'd probably prefer sub-Q over IM. And it's every 1 or 2 months. It's called Uzedy, company's Teva. And this is only approved for schizophrenia. It does not have the bipolar approval. But there's another one on the market. It's been there for a little while, Perseris. This one has a number of significant administration and storage and other advantages. So what do you think about this one?
I've been administering, as have many of our colleagues, IM and sub-Q over the years, and there's no question that sub-Q is preferred by many, many people. So I think this is not just a small detail. I think this is a very significant detail. And I like the fact that with UZEDY, the fact that it can be once every 1 or 2 months, that's a fairly interesting flexibility, right? And so I when I heard about this initially, I thought this is something that's going to be quite favorable with many people, because the sub-Q is for sure preferred.
Yeah, I agree. And what's really interesting is our usage of LAIs, at least for schizophrenia, has been consistently going up. And the most recent data I saw is about 18% of patients with schizophrenia are managed with LAIs. And I remember when I started out doing this, it was more like 8 to 10%. So that's certainly good. In some countries, it's 20 to 30%. It's higher.
You know, what's interesting about that, Andy, just that comment about the trajectory, and I agree, it's been going up in North America recently over the last few years. Now, UZEDY's approved, as you mentioned, in schizophrenia, not in bipolar 1 disorder. But what's interesting is that the trajectory, or the velocity of that trajectory, is even greater using long-acting injectables in bipolar than it is in schizophrenia. Both are going up, but more bipolar, which is really interesting.
Well, Roger, you'll be interested in my experience. I did the original risperidone LAI, Risperdal Consta study for bipolar.
Wow.
Yeah, my original thought was, how am I going to recruit for this? I was shocked, Roger, how many patients, when offered this, said, yeah, that'd be convenient, sure.
Yeah.
I'd not have to take a pill every day, you know. So interesting.
Yeah,
this also adds to the very strong and growing body of evidence of the superiority of LAIs over oral. And there's even now a lot of evidence of using them early in the illness, early in their career, as I like to say, when you really have the most, I think, to gain or the most to lose, if you will.
Right.
So, speaking of that, we do have another LAI option. We have an aripiprazole LAI. It's intramuscular, and it's administered every 2 months. So this is the equivalent of Abilify Mentena, but for the 2 month, that's a 1 month. For the 2 month, it's called Asymptify. And this one is the other one that has the approval for schizophrenia and bipolar 1 disorder.
Yeah, absolutely. Look, we all know aripiprazole came out in, over 20 years ago. 2002 was the oral. But we've had, in fact, the once monthly Mentena going back a decade already, if you can believe it. Yep. And Asymptify represents every 2 months against Mentena's every month. The active moiety is still aripiprazole. This indication, as you know, Andy, came about through a study that largely looked at kinetic similarity between the once monthly Mentena and the every 2 month Asymptify. And the bottom line is that from a kinetic perspective, which was the overarching aim, there was similarity in these two formulations after a period of 8 months. And overall, the tolerability and the safety was pretty similar. So we're really talking about, again, this is an option. A lot of people that I have seen over the years prefer once a month. Some prefer every 2 months.
Sure.
I think, again, I think it's a nice additional option.
Yeah. We do have another 2 month option, of course. Aristada, the other aripiprazole LAI, has already had that 2 month option. So again, it's nice to have more options. But you know, Roger, we still only have basically 2 molecules available. You know, there's risperidone, and of course, paliperidone is the active metabolite of risperidone. So essentially, it's the same active moiety and aripiprazole. Now, here's the exciting part. When we talked about the UZEDY, this uses a very interesting technology from a French company called Medincell. And they've just initiated a study with an olanzapine version, subcutaneous.
Very cool.
Boy, that would be cool, wouldn't it? Yeah.
That's very cool. And you just reminded me, Andy, many of our colleagues joining us are very familiar with Mentena. And many would remember you have to have antipsychotic for the first 2 weeks after you start Mentena. Right. And carbon copy all of that for Asymptify. Again, it's the same thing, a 2 week antipsychotic oral after you do the first injection.
Well, thanks for reminding me. Another advantage of the risperidone subcutaneous is no oral overlap, no initiation regimen. You get therapeutic within 24 hours.
Right, absolutely.
And same thing with the olanzapine. This technology gives you a little initial burst and then a consistently. So I think it'll be wonderful to have another molecule. I did the trials with the olanzapine IM LAI called Relprev, and it was just incredibly effective, Roger. Problem, as we know, is this idiosyncratic, it's called PDSS, post-injection delirium sedation syndrome, which requires at least 3 hours of post-injection monitoring and a REMS program. So assuming that this one doesn't have that, I think it's going to be a big deal too.
I agree with you.
Yeah, so some of these we're talking about platforms that you can use other molecules. And I understand that there are some others in development. Our friends at Intracellular are working on a lumateperone LAI, which would be a big deal too.
Absolutely.
All right, moving on to mood disorders, there's actually been a few approvals there. Yeah. Yep. One that I'm particularly excited about is zuranolone, which the brand name will be Zurzuvae, for postpartum depression. And this is a GABA-A positive allosteric modulator. So, Roger, you can treat depression through glutamate or through GABA.
You sure can. And this is the conceptual framework, as you know, Andy, of so-called excitation inhibition. And we don't talk about GABA as much in the world of mood. No, but I think the short story is there are GABAergic dysregulation in depression. And there may be, in some ways, an attenuated GABA signal in some people. And, we always say location, location, location. Well, where those GABA receptors are they synaptic or extrasynaptic matters? Right. And this is targeting not just the synaptic, but really those extrasynaptic antidepressant receptors. Right. And so the fact that it's been indicated, look, urgency in alleviating depression applies to everybody. Absolutely. I think we're going to agree in postpartum depression, rapidity of onset of action can never be more urgent. And so it's really important. It's a couple of weeks of oral treatment. And many of our colleagues might be saying, how is this different than brexanolone? Well, brexanolone is intravenous, and it's the natural form of the neurosteroid, while zuranolone is a synthetic, it's oral. So obviously oral is going to have advantages.
Certainly. And as you mentioned, this is a version of neurosteroids, which we've known about for a while. As you mentioned, we think of GABA-A receptors. Sometimes we think of benzodiazepines and think of alcohol and other things. But as you mentioned, the benzodiazepine binding site is distinct from the neurosteroid, and it's only seen in those intrasynaptic. I like to say, Roger, it's like an umbrella where the synapse is. These are the receptors that are under the umbrella, if you will. You like that? And then they're responsible for what's called phasic inhibition or burst inhibition, if you will. And as you mentioned, those extrasynaptic are tonic inhibition and have been much more associated, as you said, the antidepressant response. Roger, when I started my career, God knows how long ago, there were data and the reputation for alprazolam working for depression and anxiety. It was even marketed that way. And I think we've all had the experience that some patients with depression do very well with augmentation with a benzodiazepine.
Absolutely. In fact, I remember many years ago, there was a wonderful meta-analysis from the Cochrane Group showing just that brief exposure to antidepressants improves health outcomes in depression. And many people say, well, no wonder, because it helps people sleep. Well, that's not entirely the story. It seems to also have an effect that's positive in some people and may even reduce some of the activation for the newly initiated SSRI. I think it's a nice point. People don't often refer to that, but I agree with you.
Yeah, I'm just, talking mechanistically about GABA, as you said. We just don't talk about that as much. I think we think about it in neurology for seizures and maybe pain and things like that, anxiety, like you said, sleep. Anyway, all right, so that's very exciting. Now, this drug is also in development potentially for regular old MDD. That's been hung up a little bit, partly, as you mentioned, because this is a 14-day treatment course. And the question is, does it really hold a charge, if you will, or maintain the efficacy over time?
Really good point.
We'll see what happens with that.
You know what, Andy? I heard at a meeting not too long ago at the ECMP, actually, in Barcelona, somebody said that zuranolone is the first GABAergic antidepressant. And it was a panel that I was on. I just said, well, actually, it's kind of the second, because the first one was probably phenelzine, the monoamine oxidase inhibitor. We all know that phenelzine is a monoamine oxidase inhibitor, but it's also a GABA transaminase inhibitor.
Did not know that.
Boosts GABAergic function in a very big way. Wow. And what's interesting is I still use not first, second, third, or fourth line, but I see very late stage illness and so on and depression. I still use MAO inhibitors, and I find them very helpful for anxious depression.
Absolutely.
And the theory for years has been that's because they are boosting GABAergic function by inhibiting GABA transaminase along with MAO. Wow. So it's pretty interesting.
Roger, you are a veritable font of knowledge, and but it also is something, a conversation you and I have had before too. Yeah. Sometimes we're finding some of our drugs have mechanisms we didn't fully appreciate initially, and so these drugs may be very multimodal. I remember again when I started my training was actually right before SSRIs, right before fluoxetine was approved, and MAOIs were absolutely the most powerful antidepressants, and I don't know if you remember, they were especially effective for panic disorder, for anxiety disorders.
Absolutely.
As you mentioned. And, I think we've kind of gotten away from those. We're afraid of those, but I completely agree with you that they certainly are an option that need to be considered, need to stay in our algorithms, if you will.
Yeah, absolutely.
Okay. Moving on, we have one. This one's funny to me, excuse me for saying this, because when I started my private research career after I left academia, I did a study with this drug. It's well over 20 years ago now, and it has had a very long and tortuous regulatory and developmental history, but it is finally approved, and it is gepirone extended release called Exua for MDD. Now, you might notice, Roger, that kind of sounds like buspirone, doesn't it?
It sure does. And gepirone and buspirone they do have ancestral sort of relationships.
Right.
They're so-called azopyrones, as you know. And it's funny, Andy, I had the same reaction when I heard gepirone, because it's obviously, it's a bit like dextromethorphan. It's a drug that's been around for a long time. And then all of a sudden it just had its debutante, so to speak. and gepirone, it's interesting. I remember back in the day, Andy, when buspirone was being looked at, of course, as you know, not just in anxiety, but also as an augmentation in MDD, that there was some early work showing that it had D3 activity. And of course, we know D3 with cariprazine and pramipexole. And I really wondered, I don't know, I'm thinking out loud if gepirone even has D3. I don't know if anyone's looked at that, but it's an interesting drug.
Well, it's a 5-HT, it's thought to be 5-HT1A partial agonist, although it's much more potent at the receptor than buspirone, which may explain its better or enhanced antidepressant activity. But I'd be willing to bet anything, Roger, that you're right, that there's other things going on in addition to that. And so, certainly a good addition. It predicts not only an antidepressant effect, but anti-anxiety effect. Right. And also, it's a reasonable thing to combine with an SSRI, would you agree?
I sure would. And of course, our colleagues who are joining are, wondering, well, what's the sexual dysfunction rate like? What's the weight gain like? Well, it seems to be placebo level. Yeah. I just wrote a paper recently, Andy, for the American Journal on psychotropic drug weight gain. I went back and kind of looked at some of the older literature again, including gepirone, and did not find any weight increase over and above placebo with this medicine. Yeah.
That makes sense. Mechanistically, certainly makes sense. All right, moving along. And if I could just put a coda on this, two other drugs we have available that are SRIs plus 5-HT1A, either partial or full agonists, are vortioxetine and vilazodone. Yeah. And we know that those are not associated with sexual dysfunction either. So this mechanism maybe predicts that.
Right.
All right, moving on, we have an older friend, I would say, a drug that was approved in 2017, and this is valbenazine, Ingrezza. It's a VMAT2 inhibitor, was approved in 2017 to treat tardive dyskinesia, but has now been approved for chorea, Huntington's chorea. And the other one that's commercially available, deutetrabenazine, already had that approval. Now, I guess this is not a new molecule. Maybe this should have actually come into our updates and existing labels, but still interesting. Huntington's, not a common disorder. Maybe only about 30,000 people in the U.S. have it, but, certainly a very important addition.
Yeah, absolutely. And I think that's an unmet need population. It's a small population, relatively speaking. But look, each person who has it, that's their life, and this is an important treatment for them. Yeah. And there's such a paucity of treatments. So this is good news. I think we've gotten to know valbenazine. It's been with us now for 6 years. Absolutely. It's safety. Yeah. It's well established. It's tolerated, very well tolerated.
Absolutely.
And I think it's part of a larger, thesis that it does have a predictable, meaningful effect on abnormal movements and from different origination.
Roger, I was interested to learn from you that the incidence of tardive dyskinesia appears to be higher for mood disorders, or maybe the total number, I think it was.
Yeah, that's right. There does seem to be that case, and this has been carried forward for years in the field, and it's been more recently looked at with some of the newer drugs, second generation antipsychotics. It does appear as though the mood group may be slightly more susceptible to tardive dyskinesia consequent to dopamine receptor blocking agents.
Absolutely.
And I mean, we see it in schizophrenia, as you know, Andy, as well as in other conditions, but certainly the mood group seems to be at a little higher risk. One other part, it's separate from this conversation with valbenazine, is weight gain with psychiatric drugs, more narrowly antipsychotics, that might also be more common in mood patients than psychotic patients. I mean, there's some literature on that as well.
Actually doesn't surprise me. We all know that association with obesity and metabolic dysregulation. But, the way I very simply conceptualize this, Roger, is the dopamine system is clearly different in patients with schizophrenia versus those with mood disorder. We know that patients with schizophrenia can really tolerate all side effects a little better. And can tolerate higher doses even. So that certainly makes sense.
Yeah, absolutely. And we accept the premise that drugs may have different profiles of efficacy in, for example, psychosis and mood. So it shouldn't surprise us that the side effects of drugs may not be identical across different diagnostic groups.
Certainly makes sense.
Yeah.
All right, now we're moving into a broader CNS indication rather than a purely psychiatric. Another CGRP antagonist has been approved for migraine, and I'm going to try to struggle through the name of it. It's zavegepant, and the brand name is Zavzpret, Zavzpret.
That's awesome.
And, this is a nasal spray for the acute treatment of migraine. We have other CGRP antagonists, either monoclonal antibodies that are given intravenously, or we have some oral receptor blockers, if you will. But now we have a nasal spray, which can be very effective for those acute treatment. We know that intranasal and inhalation, Roger, are some of the fastest ways to get something into the brain, certainly faster than oral.
Yeah, absolutely. And, this whole class of drugs that Andy, has really been innovative and has been really a leap forward in the therapeutics of migraine. I never signed up when I signed up to become a psychiatrist with an interest in mood disorders to become a migraine person, but I became one because I think most know that depression and migraine coexist at a very high rate.
That's right.
And especially in bipolar. In fact,
that's right.
I was reading a paper recently because we did a study looking at migraine and bipolar disorder.
Yes, you did.
The population, we found a very high rate.
You found a 2.5 times higher incidence of bipolar in the. I quote that paper all the time. That's one of my 5 clues to bipolarity, actually.
Yeah, it's like one of those maybe soft probabilistic features of bipolarity.
And what was interesting too was you found the risk elevated in both men and women. It was a little higher, about 3 times in women and 1.5 in men. The averaged out to 2.5. So not just women.
Absolutely. Yeah, it was interesting, especially in bipolar 2, more than bipolar 1. Yeah, bipolar 2 may actually be a little higher. And when I was doing that study, we came across a study that some colleagues did in a migraine clinic. Up to 10% of people in a migraine clinic have bipolar.
My goodness.
Now, we know major depression overlaps, but bipolar has a higher risk ratio, if you will.
Wow. Certainly interesting. And of course, it's interesting to speculate on the mechanism or the biology here. Neurotransmitters may be involved, electrical conduction, vasoconstriction. Any thoughts on that?
Absolutely. It's really interesting. And going way back, I mean, when I first heard about the calcitonin therapeutics, we've been poaching and cross-purposing medications in medicine forever. And lithium, as you know, for some people can really decrease the frequency of recurrent migraine. And that's been well described for years in the literature. I mean, it's not considered a gold standard treatment for migraine, all of that. But there's been this overlap of therapeutics. And I did wonder whether or not there was something in the molecular effects of calcitonin drugs that may also have implications for mood, because there's always this sort of, cross-purpose opportunity.
Absolutely. I remember, Roger, early in my career, we were looking at calcium channel blockers for bipolar, if you remember that whole story.
Of course.
And I wonder, Roger, over the years, sometimes people have said there's been a lack of innovation. I absolutely disagree. Over the years, I've studied lots of sexy new mechanisms, I like to say. And they failed not because of a lack of innovation of the molecule, but of a lack of biomarkers, of being able to really match the target to the mechanism. And I think that's why something you said earlier about mechanistically informed drug development is so important now as our technology advances and our knowledge of the neuroscience. So to me, this is very exciting.
It is, and the closer we are to the mechanism, then it stands to reason the better the drug would be. And it stands to reason that we could finally say, we're modifying the disease. We're doing disease modification therapeutics. So it's really interesting. This has been, again, truly innovation in the area of migraine. And I should mention, because many people ask me this, yes, many of my patients taking antidepressants or taking antipsychotics or lithium also take these calcitonin drugs, so they can safely combine them. I get that question a lot.
Well, some of the anticonvulsants, divalproex and topiramate, for instance, are effective for migraine and also may have some efficacy for bipolar. So clearly, lots of overlap there.
Yeah.
Getting back to our other conversation, over the years, I've noticed when I do some of these trials, it always seems like a subset of patients do especially well. But unfortunately, we can't always predict who they are. And for years, what we've been doing is genetic testing to try to retrospectively analyze, can we find a subgroup who did especially well and find some genetic marker that would predict this? And so far, it hasn't panned out as well as we'd like. But to poach another analogy from our oncology friends, they certainly have tremendous biomarkers that can help them select the appropriate target, the appropriate chemotherapy, if you will. We've all heard of receptor-positive tumors and things like that. Right. I really do think in our lifetime, we're going to have some of those in psychiatry, and it may not come from the usual places. There may be things like digital biomarkers or some other kinds of things.
Right.
Yeah, so certainly that's another exciting space to watch is our development of biomarkers and things like that.
Yeah, I agree with that.
Speaking of moving beyond traditional medication, we actually had a prescription digital therapy approved this year for PTSD. And Roger, at this year's NEI Congress, I gave a talk on prescription digital therapies. I have been very involved in the development of some of these. And this particular one is a non-invasive self-neuromodulation adjunct therapy called PRISM for PTSD. And the way this works is people wear a headset that has electrodes, so it's monitoring EEG, connects to the computer. Computer is showing you videos of various stressful situations. And what you do is you learn to train your brain to calm things down. And one of them, I was interested to read about this, Roger. One of them is a very busy waiting room, and people are moving all around, and lots going on. And as you train your brain, as you figure out how to, certain brain waves, people start sitting down, and the scene gets calmer and calmer. So it is literally like training your brain. It's like training a muscle, training a circuit. And the circuit they're targeting here is the amygdala to the prefrontal cortex, which makes perfect sense.
It's pretty interesting. Biofeedback has been tried for so long in psychiatry, in other areas, of course. Yep. But now the technology, I think, has taken the biofeedback, and also the end user is so real time, so in vivo in doing this. It's pretty compelling. It's pretty interesting. Yep. It seems to offer benefit. It's a really compelling conceptual framework to this.
It certainly is. And one of the things to realize, these treatments, if you will, go through a different FDA approval process. It's called a 510 process as opposed to drugs go through a 501. And this leads to them, and it's the way that things get approved as devices, more medical devices. And these things get cleared by the FDA, not necessarily approved like a medication. There are two others, Roger, interestingly, that are approved for PTSD specifically. One of them is called Nightwear, and this is using an Apple Watch. And what it does is, these watches can monitor lots of things, including our sleep, and it can actually tell when someone with PTSD is having a nightmare. It sends a vibration to their wrist, which arouses them out of the nightmare but doesn't fully wake them up. So I find that certainly
Very
interesting
cool.
to target, a specific symptom of the PTSD.
Very.
And the other one, isn't that interesting? The other one's called Free Spira. And of course, Spira makes me think of respiration. And this is a home treatment that does training around your breathing. And so it trains your breathing to build up less carbon dioxide, essentially. And that one's approved for PTSD and also other anxiety disorders. All of really the prescription, and there are several approved now for various indications. All of them are approved as adjuncts. None of them are approved as standalone therapies, which I kind of like. I think there's a potential for this to be like the Wild West out there, and we know that if you go to the App Store, Roger, there's hundreds, if not thousands, of health-related, apps that haven't necessarily gone through this rigorous testing, the FDA approval process.
Absolutely. No, look, this is awesome. As you know, Andy, we only have 2 therapeutics FDA approved for PTSD, sertraline and paroxetine. Both are modestly effective.
That is true.
And obviously exposure-based, trauma-focused therapies are a first-line therapy. But look, we have such an unmet need. And this approach, digital therapeutics broadly, yes, we see this landing on PTSD in a way that's quite helpful for many people with lived experience. But you can imagine this is just the first inning of the baseball game with potential application to other conditions, Andy, including but not limited to depression. I mean, biofeedback, in those areas as well. So it's very, I guess, just what I would say is stay tuned.
Yeah. Well, I know you're well aware of a digital therapeutic being developed for depression through Click Therapeutics is partnered with Otsuka, and they have one in development. It's actually in stage 3, phase 3 testing, so it could be approved as soon as a year or two from now.
Right.
But you're right. We are in the very early days of this. The problem has been that payers have not jumped on board yet, which is a little curious to me because this seems like a rather lower cost way of doing this. And certainly I think it's great because people like to be able to take control and do something active to manage their illness, number one. And number two, it expands access. Let's face it, we have a major access crisis to mental health treatment in our country, especially in rural areas, and this may be a way to expand access. So I'm very excited about this.
Yeah, completely. And without the weight gain and sexual dysfunction.
Yeah, certainly true.
Yeah.
The other advantage is, of course, non-physicians can prescribe this. For instance, a psychologist, perhaps a well-trained therapist, which again expands access, and that can't be a bad thing.
Absolutely.
All right, let's move on to the updates to existing medications. One that I know you and I have been particularly involved with is cariprazine now has the adjunct treatment for unipolar MDD, which is a very important advancement. We certainly need more effective treatments for that. And now cariprazine joins quetiapine as the only two that have what I call the pan-depression approval for both bipolar and unipolar depression. What do you think, Roger?
Look, this is, I think, for a lot of people, they're probably saying, well, I've known this all along that it works in major depression. I've been using it there, right?
Yes.
But look, this is just a logical extension. This is a D3, preferring D2, D3 partial agonist with 5-HT1A agonist. We talked about that earlier. I also think, Andy, you and I have talked in the past about 5-HT2B antagonism. I think that could be potentially antidepressant. The story with viloxazine is an example. So this is a story about a drug that clearly has a benefit in cognition and reward. So therefore, yes, bipolar depression indication, unipolar depression indication makes great sense. I mean, academically, you know this, Andy, one of the questions I've wondered is, I wonder if we could begin, and I know that the company is beginning to look at this, maybe the metabolite like D-CAR to see that's a separate drug altogether. That even has even greater D3 selectivity than does cariprazine. Yep. So it's really interesting, and I think it's finding its place, in anxious, irritable, sort of agitated, mixed patients. So I like your notion, the pan treatment like that. Yeah. Yes.
Yeah, it sort of simplifies it. If you're not sure, I like to say if they're bipolar-ish, this is certainly an effective treatment. But I certainly agree with you. We learn from each other, Roger, let's face it. And our good friend Vlad Maletic has really taught me about 5-HT2B antagonism. And it really does seem to be an antidepressant mechanism. So stay tuned.
I agree.
Roger, just parenthetically, and we can talk more about this offline. It's curious that some of the atypicals that are approved for bipolar depression are approved as monotherapy, but for unipolar, only as adjunct. It turns out there's an interesting story behind that. It has to do with FDA and regulation. The FDA was not comfortable with the risk-benefit ratio, if you will, of monotherapy, certainly is potentially first line for MDD. But seeing bipolar as a more severe illness, they were okay with that somehow. So
right.
It's very interesting. I get asked all the time, and this is not a promotional podcast, Roger, so we can say this. I get asked all the time, what do I do with the antidepressant? I've got, cariprazine on board. They're doing really well. Do I need to continue the antidepressant? The answer may be no. The answer may be that these drugs are dyed-in-the-wool antidepressants. Certainly, you may be aware, I'm an author on a paper of quetiapine extended release as monotherapy for unipolar MDD, and it was extremely effective. So, that's interesting. The other question, the other question we get, I know you have some thoughts on this, is intranasal S-ketamine is currently approved in conjunction with an oral antidepressant, but certainly over time, we know ketamine has been studied as monotherapy. Do they need to continue the oral antidepressant forever?
Yeah, it's a great question. It really is. And I like your comment about the antipsychotic monotherapy, because you did the quetiapine work, and of course data now with also lumateperone in major depressive disorder, as you know. And so there is a story unfolding, and sometimes, the data gets in the way of the story, but the data does tell us that these drugs do have safety and efficacy as monotherapy. Some of them do.
Yes, I think so.
In major depression. S-ketamine is interesting because there's no doubt it's a very effective treatment in TRD, of course, with the indication also in those with imminent risk for suicide. Andy, you're fully versed on the New England Journal paper that was published just a few months back this year, where S-ketamine was compared to quetiapine XR in adults with TRD. Simply put, looking at remission rates at 8 weeks, looking at relapse rates at 32 weeks, just the bottom line is S-ketamine was the categorical winner.
Absolutely.
And it didn't just win on efficacy, but also won on acceptability with half the rate of dropouts. So I think that we have now not only that data, but many colleagues ask me again, after a meeting say, hey, what do you think about transitioning a patient who improved on S-ketamine over to Auvelity? I get that question a lot.
Absolutely.
It's an interesting question. I think that someone has to test this.
Yeah, completely agree. Our friend Greg Mattingly, who does a lot of intranasal S-ketamine, has told me that he has used Auvelity as the oral antidepressant and over time has been able to successfully transition just to the
that's pretty interesting.
Yeah, we'll see. Roger, what's been fascinating to me is all antipsychotics, almost by definition, are antipsychotic, but they're not all antidepressants. Right. I'm convinced of that, as you alluded to. All right, we've got to move on. Here's another oldie but goodie. This is our good friend escitalopram Lexapro. Believe it or not, just this year, got a new approval, and that was for GAD in kids 7 and older. Now, you may be familiar with this. When I was involved in the original escitalopram adult GAD studies, this was a post-approval commitment from the FDA that they finally were able to wrap up. So absolutely. Look,
there's been data that's come out, Andy, there's been even recommendations from health authorities, certain professional groups, to be screening for anxiety and depression in kids. No one's unaware of the mental health crisis in young people, worsened, of course, by the pandemic and all that terrible situation. And so, look, there are options available. And we don't forget about psychotherapy. We don't forget about family-based interventions. But this would add only to duloxetine as a treatment for anxiety in this, GAD in this young population.
Well, we certainly know that mental health issues can start in childhood. As a matter of fact, the majority of them start in childhood or adolescence, and we need more, especially safety data. We're already using these drugs, and so it helps to have that safety data in this population.
Right.
Okay, moving on. This one, I think, is very interesting and is the harbinger of more to come. Brexpiprazole Rexulti got an approval this year for the agitation, not psychosis, but agitation associated with Alzheimer's dementia. There are a number of other drugs in development for the neurobehavioral symptoms of dementia.
Yeah, absolutely. And I remember, Andy, going way back to when I was a fellow. I was training in psychopharmacology, and I used to moonlight at a nursing home. And well, the first impression I had was how underserviced, understaffed it was. Second is how much polypharmacy goes on, and thirdly, how much antipsychotic is being prescribed. And no one's unaware of the box warnings with antipsychotics about, the risk of mortality in those with dementia-related psychosis. Yet it's puzzling to many people because very wise, very astute, very thorough clinicians have observed that these drugs can help many patients with agitation. So where do we land on this? So This is an important, I think, in many ways, truth-telling, clarity, if you will, because we have an antipsychotic that treated agitation in people who had dementia as part of Alzheimer's. What I was really struck by as well, Andy, when I saw this, the first thing I gravitated to, this may just because of my interest in safety of drugs, is to look at the safety. What was the tolerability? What was the safety like? And it was very safe. And dosing, that's what we, the dosing is dosing we usually consider in younger populations. So
I completely agree.
It was well tolerated in this group, as well as, of course, being very effective on the agitation scale.
Roger, I completely agree with you. I was almost shocked at how well tolerated. At doses that we do use in younger people for mood and schizophrenia, 2 and 3 milligrams.
Yes.
Particularly, I was interested in a very low rates of dizziness and falls, which is obviously a big issue there.
Right.
Okay, moving on to our next thing. Lisdexamfetamine went generic this year. And this is a big deal for so many reasons, Roger. It's the number one prescribed stimulant for adults with ADHD. And there has been a shortage, as we know, of stimulant medications, in particular amphetamines. So perhaps this will increase access as more generic makers jump on board. And the approval here is not only ADHD, of course, but binge eating disorder in adults as well.
Right, absolutely.
So good to have that.
Good to have that,
Yeah. And then another, little more broadly CNS, we have naloxone nasal sprays, 2 of them, Narcan and Revive, approved as over-the-counter, Roger, not prescription, over-the-counter treatments for opioid overdose. This clearly is a big deal. Expanding access to this, of course, treatment has to be on-site right away, and so this will help with that, I hope.
Oh, absolutely. Absolutely. I mean, we're all aware of this terrible crisis with the opioid pandemic. It's over 100,000 people in the last year have died because of opioid poisoning. Yeah. To have this over the counter, I think it's fantastic.
Me too.
Yeah.
All right, moving on to the other VMAT2 inhibitor we alluded to, which is deutetrabenazine. Deutetrabenazine was a little less convenient to use than valbenazine. It was twice a day with food. And recently, an extended release once-a-day preparation called Austedo XR was approved. And Roger, it's not only once a day, it's with or without food. So I think this kind of narrows the convenience gap between these 2 very effective medications for TD.
It does. And again, we need more options. And I think many of our colleagues are wondering, Andy, if my patient tries one and it doesn't work, is it futility to try the second, vice versa? And I would say no, because as much as we have hypotheses about mechanisms of actions of our medicine, for reasons we just don't know, some people don't respond to one SSRI, but they respond to the other one.
Exactly.
And that also holds true to these medications. So more options is better. I think, as you said, or alluded to, closing that gap difference around the frequency, I think is great.
Could not agree more. Does still require a titration. And to your point, these 2 medications, deutetrabenazine and valbenazine, are actually, Roger, different molecules. There are 4 active metabolites of tetrabenazine, the parent, if you will. And it turns out valbenazine is the plus alpha metabolite, and this is more of the plus beta metabolite. Right. And so they are literally different molecules with slightly different affinities for VMAT2, and potentially deutetrabenazine may have affinity for some other receptors. And so I completely agree with you. If someone doesn't do well with one of these, do not give up on the VMAT2 as a mechanism. You should absolutely try the other one. So very important. And then just a quick thing we have to say in honor of our good friend Les Citrome, please cut back on your use of anticholinergics such as benztropine, which does not work for a TD. VMAT2 inhibitors are the way to go for TD. Okay, with our remaining time, Roger, we've had some very interesting articles that came out this year that I think really inform our use of psychopharmacology. So just checking through the list here, I'm going to start out with one that is very near and dear to my heart as somebody who's done a lot of work with ADHD. And this was a long-term safety study, 2 years long, very rigorous, of methylphenidate in children and adolescents with ADHD, published by Mann et al. In Lancet Psychiatry.
Yeah, look, a very nice paper, and I think the key part about this, I really enjoyed the paper, is that, look, we need long-term safety tolerability data. And much of the data, as you know, Andy, comes from, observational studies or retrospectives, things like that. And there's a place for that. But the rigor of this takes it to the next level. And as you know, we did not see any attenuation on, for example, growth in the folks. No surprise, a change in blood pressure and pulse, but that wasn't thought to be clinically meaningful.
Yes.
So I thought, if anything, it was actually a vote of confidence in the safety. I certainly use these medications in adults, but now we're talking kids.
Absolutely.
And so I think it just adds to the safety profile in a very rigorous way. I suspect that's why it was published in Lancet Psychiatry.
Yeah, well said. What was surprising was no statistically significant difference in the growth trajectories of either height or weight. Completely agree. And no other significant safety findings. And of course, there's a lot of misinformation and unwarranted, I would argue, fear around this class of medicines.
Right.
One thing that's important to realize, as we mentioned with the two VMAT2 inhibitors, methylphenidate and amphetamine have some similarities, but they do have some important differences. And amphetamines are more potent, particularly with respect to releasing of dopamine, tend to have a little bit more anorexia, decreased appetite, possibly a little more growth retardation than methylphenidate. So that may be part of the reason, Roger, we use more methylphenidate in kids and we use more amphetamine in adults, although adults can respond to methylphenidates, as we know.
That's right.
All right, Roger, one that's I know near and dear to you is there was a study looking at adjunctive antidepressants. This particular article looked at escitalopram or bupropion XL in the maintenance treatment of bipolar 1 depression from Yatham et al. Published again, Roger, prestigious journal, New England Journal of Medicine. This was a Canadian group, friends of yours.
Yeah, absolutely. Look, I think there's no question that's more probably confusing, polarizing, radioactive than the role of antidepressants in bipolar disorder. But the short story is that we are landing on an evidence-based conclusion that's, yes, most antidepressants have not been shown to be effective in bipolar depression. None are FDA approved in bipolar depression. And they can destabilize some susceptible people. There's no question about that, although the number needed to harm is close to 200. So it's not a very common event of destabilization. This study, I think, is critical because it looked at long-term. And long-term, we have very few studies of antidepressants in bipolar. There's two ways to interpret this study. You can just look at the bottom line, which I always do, and then you kind of look at the study with a bit of nuance. The bottom line was there was no additional benefit by keeping people on antidepressants for a long period of time, that is out to a year when compared to 8 weeks. That would be the bottom line. I carefully looked at this paper, and a careful look at this paper leaves one with, I guess, a testable hypothesis, but an observation that informs the hypothesis that there are some people actually who do better just by staying on the antidepressant.
Yes.
And I think to your point earlier, Andy, about biomarkers, we need to find a way to biophenotype people because clearly one size doesn't fit all. Heterogeneity, not just causative, but phenotypic heterogeneity is what psychiatry is all about. And so a one-size-fits-all rule with respect to therapeutic recommendations doesn't seem like it's going to apply, and it doesn't. So some people, I think, are going to benefit. So the bottom line was, of this study, there wasn't, at the group level, benefit by keeping on antidepressants longer, but within the group, there were subpopulations where they did seem to do better by staying on the antidepressant.
Yeah, I love what you're saying, Roger. I've said for many years, buried within averages are individuals,
Right.
if you will.
Right, that's right.
Well, and bipolar, we know, is so highly heterogeneous as most of our disorders are. We know that the International Society for Bipolar Depression guidelines a few years ago on the use of antidepressants did say there may be a role in certain patients, such as bipolar II patients. But something else I want to muse with you about is the issue of if somebody's been on an antidepressant for a while and you want to take them off. Our good friend Rifel Malak published a very important paper on the acid syndrome, he called it, that if you taper someone off too quickly, they almost get a rebound kind of situation.
That's right.
So if you're going to try that, my advice, of course, would be to do it carefully and slowly. But you're right, we've all had that experience of a patient that seems to just need an antidepressant. But of course, what I always say, speaking of evidence-based, is there are FDA-approved treatments, and we should at least be using those first. And we should try to do everything we can, short of using, a non-evidence-based, unapproved treatment. And yet, as we know, still the number one prescribed class of medicines to patients with bipolar is SSRIs. And I think it's almost a semantic issue, Roger. Our brain says they're depressed. I want to give them an antidepressant.
Right.
And people may not realize unipolar and bipolar may be different animals.
That's right. And also, look, the heterogeneity at the phenotypic and at the causative level is huge in bipolarity. And within that heterogeneity, yes, subpopulations, but within the subtypes, I think the conversation is very different for bipolar 2 than bipolar 1. Bipolar 2, Andy, is a very serious phenotype, maybe even a higher rate of suicide than BP1. Yes. Yeah. And it does appear that people who live with BP2 do not have the same vulnerability to affective switch or to acid, that RIF coin. I love that acronym. And I think that's all true. I love what you said, Andy, about discontinuing antidepressants. We don't say enough about discontinuation-induced hypomania. That can sometimes happen, perhaps maybe because it's the sleep disruption that some patients have when they suddenly stop an antidepressant. I don't know. But we don't say enough about that.
Roger, it's interesting. Our friend Jonathan Myers is writing an article now on deprescribing medications, particularly anticholinergics. As we're thinking again about with movement disorders, tardive dyskinesia, I always say anticholinergics like benzodiazepines. Once you start them, nobody stops them. So I think it would be very helpful to have some guidance on deprescribing medicines. And I always joke, Roger, sometimes I've done more good in my career taking people off drugs than putting them on drugs.
Absolutely. That'll be a nice paper.
Yeah, I'm looking forward to that.
Yeah.
All right, we have a couple more papers to discuss. Another one, Roger, that I know you're going to have thoughts about is a treatment using subcutaneous racemic ketamine for TRD. And this was published again in a very prestigious journal, the British Journal of Psychiatry.
Yeah, it was. It's a nice paper. It's from an Australian group, a very, very good group, a very, very scholarly group. And look, this is another option. IV racemic ketamine and intranasal been the most studied. With S-ketamine, of course, the intranasal has 4 years of prospective data on safety. So that clearly is in a league of its own, followed by IV racemic ketamine. This is sub-Q. We talked about this earlier. It's easier to take, much more acceptable. This group showed safety. They showed efficacy. They had to increase the dose a little bit throughout the study. That's what we would expect anyways. But look, I think this is the strongest line of evidence supporting sub-Q as an option. I would, however, say, though, we still land on IV racemic, which recently was shown in a separate New England Journal of Medicine article. This was a PCORI funded study showing it's not inferior to ECT. So IV racemic ketamine is a heavyweight player. It's a very significant option with dozens of controlled studies with intranasal, of course, and it's been proprietary and approved. But this has actually moved sub-Q up the list. It's still third on the list, but it's an option nonetheless.
Yeah, so it sounds like you would say IV is kind of the gold standard, although there are these other ways of delivering it parenterally. Some people give it intramuscular. There are certainly sublingual preparations. So very interesting world we're in. Of course, racemic ketamine, really not FDA approved or approvable, if you will, but as you know, there's all kinds of variants of ketamine, the R isomer, various metabolites being studied. So
yeah, that's right.
Lots of ways of slicing this. All right, moving on. This is one that I'm particularly interested in. This is the safety and risk of relapse associated with, get ready, I'm going to say a nasty word, Roger, antipsychotic polypharmacy versus monotherapy. And this is from Taipale et al. And then she's published some tremendous work out of a group in Finland with Tahonen. American Journal of Psychiatry, another prestigious journal. Yeah. The shocker here, Roger, was polypharmacy was found to be superior to monotherapy, not for efficacy, but for complications, for non-psychiatric hospitalizations, in particular cardiovascular.
You know, Andy, you should be ashamed of yourself for talking about antipsychotic polypharmacy. Shame on you. Well, look, this is like taking the dirty laundry out of the house and saying,
exactly.
Hey, look, I was reading a paper recently, on the low end, 25%, on the high end, close to 40 to 50% of people prescribed an antipsychotic receive antipsychotic polypharmacy. So it's happening. And I think what clinicians are reacting to, they're seeing it work in some patients, but where's the data? Absolutely. And this is a wonderful paper because it's a nice method, it's a big sample, population-based, all that good stuff, and they reduced non-psychiatric and cardiac hospitalizations. And I think that in some ways, I've always thought that we've kind of contradicted ourselves in the sense that we always say we don't know what the mechanism of action of an antipsychotic or other drugs are, but don't combine two antipsychotics together. And I used to always think, that seems kind of, well, why are we sort of so, orthodox on this? Why are we not open-minded? Yeah. And I think that the line is now blurring with respect to what is an antipsychotic. And I think that that's unnecessarily kind of restricted us. It's a nice paper. Many clinicians over the years have added, as you know, Andy, aripiprazole or other drugs to clozapine and things like that. People have been doing it, and very experienced clinicians see benefit when they do that. So I think this is, in many ways, in accordance with what many clinicians have. Many clinicians have had that light bulb moment combining antipsychotics, and I think this kind of instantiates it.
Well, you're right, Roger. This is our dirty little secret. And in this particular paper, they found 50% of patients were being treated with polypharmacy. As you mentioned, it's not an insignificant number. And I like to say we vote with our feet. Clinicians vote with their feet. I believe in the wisdom of the seasoned clinician, Roger. And sometimes we do things because we have to. They just work. And, it is de rigueur in other fields of medicine to do this. If you're treating hypertension or diabetes, for instance, it's common to combine two medicines with putative different mechanisms of action here. And the fact is that our antipsychotics do have while they sort of overlap around the dopamine, the D2 receptor, beyond that, they have very different receptor profiles and so on. And so certainly it is not irrational polypharmacy to just categorically say don't use two antipsychotics.
Absolutely.
It probably is irrational to combine certain ones that might have very similar mechanisms, but not all of them. So I think this is great. And what I love is they challenged the orthodoxy, and they said, look, our treatment guidelines all say monotherapy, 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 but why? Why aren't we more agnostic about this or open-minded, as you said?
Agreed.
All right. Finally, another one, Roger, right in your wheelhouse, and you gave a tremendous talk on psychedelics at the NEI Congress very recently. This one is one on MDMA-assisted therapy in moderate to severe PTSD, and this is one that I know has created a real stir in our field.
It has. As I said earlier, Andy, as you know, trauma-focused therapy, sertraline, paroxetine, that's what we have. Sertraline, paroxetine, modestly effective. Their effect size is around 0.3 to 0.5 in PTSD. This is compelling. This is replication of a phase 3 program. This isn't a standalone study. This is a replication of previous study showing an effect of the MDMA-assisted treatment to treat PTSD. A lot of these people had dissociative PTSD. They had depression. They had alcohol and drug abuse in the recent past. This was a complicated group, and the effect size was close to 0.7, 0.8.
It was 0.7. That's right.
Yeah, it's a nice effect size.
It certainly is.
So it's interesting. There's obviously many questions about long-term. There's not long-term data here. This is shorter term. Of course, long-term safety. We talked a lot about that NEI this year, about the need for including valvulopathy studies and things like that. But I think it's clearly very promising. And I think the other question is around implementation, the role of psychotherapy, and those questions are going to need to be sorted out because there's going to be an access availability issue here if this level of psychotherapeutic intensive support is sine qua non, is mandatory. So those ought to be sorted out. But this is very hopeful data for a very difficult to treat diagnosis.
I certainly agree with you. And this drug has a different mechanism of action, as we know from the classical psychedelics. We now divide these groups into three categories. We have the traditional psychedelics, such as psilocybin, LSD, that putatively work through serotonin receptors, especially 5-HT2A, although, as you and I know, there's lots of other mechanisms involved. Then we have the dissociatives, the ketamines, if you will. PCP falls in that category. And then we have here the empathogens or entactogens. MDMA is commonly called ecstasy, that may work through more traditional monoamine type mechanisms. But all of them are being studied now. And the problem, of course, as we know, is for political reasons, back in the 70s, they were thrown into the bucket of Schedule I drugs, meaning no therapeutic use, which makes no sense. They've all were originally developed potentially therapeutically. So that's going to be an issue. They may have to be descheduled. The regulatory authorities might have to do something to help with wider use. There's implementation issues. There's how often do we give them issues and so on. So very exciting. And Roger, I have to give you a shout out to another one of your articles that I've been quoting is your provocative article, Is the Trip Actually Necessary?
Yeah, I guess that's to be determined. I think that's held sacrosanct by some folks. Look, it might be the case that you might need the trip in some cases. It may be different as a function of which medication. You talk about dissociatives, the serotonergic psychedelics, and the entactogens. Maybe it's different for each category. I don't know.
Well said.
I think we have to be open-minded. It could be the case it is contributory in some scenarios, but I still land on it's a testable hypothesis that the trip is required. We had initially thought dissociation was required for ketamine to work. That was actually proved to be untrue.
Right.
And I always use this example, Andy, and I think there is some application. When I started my career, not too long after you started your career, we were dosing the antipsychotics on the ward to achieve EPS because we thought that was the minimum dose to get therapeutic efficacy. It turned out that our theory was not quite right. You don't need to have EPS, and so sometimes these dosing drugs to achieve a phenomenon because you think it's actually integral to the therapeutic effect. Sometimes that can trick you, and I just sort of I'm sort of being I'm on the fence on this whether you actually need the trip or not. I'm open-minded to it, but I'm not accepting it without any kind of proof, and that's where I land on it.
Well, Roger, I don't know if you realize this, but you and I will be debating this topic in Brazil in a couple of weeks. And I suspect
it'll be a psychedelic argument.
It will be so much fun, as many of our discussions and debates have been. I think it's all TBD. It's all yet to be determined here. The role of, I'm like you. I think I'm on the fence here. I'm willing to be open-minded, and these are testable hypotheses. But I just think about the fact that our best outcomes, particularly in mood disorders, have been shown to be a combination of medication and various evidence-based therapies and also lifestyle interventions.
Right.
Why shouldn't this be the same? Why shouldn't, let's say, the medication's doing some of the heavy lifting here, but why not have the therapy as part of the experience? I've probably told you this story. A dear professor of mine at University of Virginia, Dr. John Buckman, was doing some of the original research with LSD, and the theory was it was unlocking the unconscious mind, and so you would do psychotherapy. And he actually gave LSD to Cary Grant, and that's a whole nother story.
Oh, wow.
Yeah. Well, with that, we have run out of time, my friend, and boy, we could just go on and on. I want to just thank you, Roger. It's been really enlightening.
Really fun. Thank you, Andy. It's good to do this.
Sure. Yeah, and I want to thank you, our audience. I hope you found this to be helpful. And, it goes along with us at NEI. We're always trying to stimulate you and get you to really be up on the latest and even things that are on the horizon. I want to thank you all for listening and staying abreast of this information. And for more information about our various educational offerings, please go to our website, which is neiglobal.com. Thanks so much. Take care.
Thanks, everybody. Take care, Eddie.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.